in the healthcare world, you've probably heard of direct primary care or concierge medicine within the recent time frame. A lot of times people usually switch over to one of those methods where they feel like they can get more personalized care, or I've seen a lot of providers scooch over to that space when they feel super duper burnt out. There are kind of two sides to there's people who really love concierge medicine or direct primary care, and then there's people who are unsure. And I have my feet firmly pretty much in both camps. I can see the benefits. I have concerns. I think it almost goes back to a time like we're reverting in terms of primary care. Like we're kind of going back to like house calls and everything like that. We're kind of going backwards. I'm not sure if it's bad. I don't think that part's necessarily bad. It's just interesting. So today we're going to discuss the difference between direct primary care and concierge medicine, because even there's no like technical definition, but they're different, kind of some pros and cons surrounding them. And yeah, other discussion. It's a panel discussion. So we have all of our wonderful panel members here. Say hello to them. I think we've all been here before. Everyone want to go around real quick and just give a brief introduction to yourself, and then we'll get going. And if you have any questions about direct primary care, let me know. I will be leaving timestamps with like specific questions down below. And if you're watching live, I'm sorry I'm late. Philadelphia would not let me leave. I was in traffic and they said, you know what, when would be better than this hour-long drive if it was 2 hours. And I was like, wow, okay. So here we are. Thanks for being here.
I'm Adrian RN. I'm going to just jump in because I know we're
perfect.
Like, people have been waiting.
I know.
I'm Adrian RN. You guys know me. I've been here on the panel. Thank you so much, Liz. My information will be in the bio. I'm a nurse. I'm an MBA, and I'm down for this conversation. Next.
Hi, all. I'm Mr. Midwife. I've been here before. Enough said.
He's Chad. He's a midwife.
Liz and I agree on most things. We're pretty vocal about it.
We have me and Chad are doomsdayers, and then we have Scott, who is our voice of calm and reason.
He's the cool one.
Hey, everybody. My name is Scott. I have the Nurse Scott YouTube channel, and I was an emergency nurse for decades. And so who do you want in your emergency room? Somebody who's going to freak out every time somebody stops breathing, or someone who keeps their cool and is able to just kind of think their way through things. And so that's, I think, where that comes from. So I'm happy to be here. I did a little research on this topic last night and this morning, and I'm happy to be here.
Yeah, I'm very glad all of you are here. Thank you. And for rolling with the punches on. I'm like, oh my gosh, we're changing the time. Everything is happening. I'm a hot mess. Scott, I would also like to have it on the record at the very beginning of the show. Scott was not, so panel members are obviously required to come to all streams. They are unpaid for everything, but they must come to everything to have the pleasure of donating their own time later here. It's very, very, very prestigious. They do, please go check out their channels and their links down below, because they're helping me out hugely here, and they have beautiful platforms where they share all sorts of wisdom. But Scott missed Tuesday, and I do want to point out that it was requested that he bring a note, and he did. So this is Scott's note from his mother. It says, "Dear Nurse Liz," she wrote it, "please excuse Scott from attending the Late Night Liz on Wednesday. He was taking a much needed break from his studying and took the dogs to the dog park. Thank you, Nurse Scott's mom." So we appreciate you bringing your note. You are excused. Don't ever let it happen again.
That's right. Sorry.
Yeah, but we do accept your apology. So thank you. And I appreciate the note. Okay.
I'll let my mom know. She says she has watched the channel and she likes you.
Oh, well, thank you. Tell her I like her and I like the human she raised. Let's see. I'm going to put a poll. Do you know anything about direct primary care? Do you guys know anything about direct primary care? We'll put a poll in the chat. And you guys?
Yeah, it was pretty popular where I lived. It was definitely gaining steam because I kind of lived right between halfway to Santa Barbara and halfway to Calabasas. So between two populations and pretty wealthy people. So there was a lot of doctors who were leaving our hospital and moving into concierge.
Yep.
And that was, I felt like other than maybe New York City or Miami, I felt like I was in ground central of that movement, especially in the entertainment industry. So I could see the appeal of it for control and access and immediacy within the paradigm of people who are used to having everything they want when they want it.
Mm-hmm.
That component
Yep.
of it and access, versus I waiting for an appointment for months. There certainly is some research out there that shows there are no difference in outcomes. But there's a financial component. Obviously, it's very exclusive. This is not something cheap, but it's also, there's another component I thought about that I actually just utilized, which was a fee for service. I actually had to get antibiotics a couple weeks ago, and I utilized a service that wasn't concierge. It was more just on demand through video. And, it was $35, I think. And I got antibiotics and it was awesome. It all happened in 30 minutes and it saved me going to an urgent care, hanging out in an area I didn't want to hang, just the time saving. So there is some entry points that are lower than the monthly kind of concierge rates of, $1,000 to $2,000 to $5,000 a month.
Yep. But, yikes, that's a lot. But there's all different tiers. And we're going to be talking about that today because I was much more familiar before I started really diving into this with the concierge side that was very expensive. But there are other parts of like direct that try to be more affordable, but it still is an increased cost above your normal insurance. So we're going to kind of talk about that today because I wasn't overly familiar with that. And it's quite intriguing. But yeah, if you do the concierge side and you gussy up to all the rich people and you deal with all their craziness, it's a lot of money. That's a lot of money. So any experience from you, Chad or Scott?
I worked for a very short time, and let me emphasize very short time, for a concierge clinic. And the clientele were the upper crust. As Adrian said, they walk in, get what they want, lay down a couple of Ben Franklins, and they walk back out. And the care was about equal. They're just sometimes not very nice people.
Yeah.
Can I say that?
Yep. It can be a wee bit different. And if you guys have ever
that may be something I have something to say about. I don't have any experience in concierge medicine, but I did work at a large hospital in Los Angeles where the rich and famous and tended to go. So I have had brushes with greatness. And
yes.
To be honest, the people that you would recognize from TV and music and all that are very nice. It's the rich people that you don't know who can be demanding.
Because you don't know who they are. How dare you?
I will, just a short aside, if you donate a lot of money to a hospital, and this hospital, everything was named. The nurses station had a name of whoever donated money for that. Each room had a plaque. Somebody donated a certain amount for that. Some people had their name on the side of the building. That whole wing was endowed by them. You kind of expect when you walk in the door that they're going to treat you, a little bit nicer. But in an emergency department, it's like, hey, we take whoever's the sickest first. All the rooms are full. You have to sit down. So I was torn. It's like, thank you for your donation, but I can't make other people wait because that's not ethical either. So and that's the thing about this whole topic is if the one video I saw was a woman back in my home state who was upset that her doctor was transitioning to concierge medicine, and sent a letter to everybody and said, basically, either you need to join the concierge service or find another doctor. Now, I think she should have arranged for them to be taken over by another doctor. But so to me, now this is kind of an issue of distributive justice. This is, are people getting what they deserve to get? Are we taking away from some people to give to other people? In general, no. There's doctors and clinics to go around. Some are paying for the convenience. But in that case, it felt to her like it was being taken away from her to give to someone else.
So one thing that's interesting is, right, so these there's estimates, right, that these panels, instead of having 2,000 to 3,000 doctors, are 2,000 to 3,000 patients in their panel. So for those of you who don't know, it's called a panel, the number of patients a provider has. Then they're going to go to like 400 to 600. So that's a huge difference. So then who picks up cumulatively that other 2,500, 1,500 patients? And we're already looking at a 22,000 to 51,000 number shortage of providers over the next few years. And this is an industry that is projected to make $6 billion next year and worth something like $30 billion in the next 10 years. So the valuation of this is, there's a component of this that's about money. It's just straight up about money. 100%. Nothing but money. Just like, again, providers are going into aesthetics. Well, that pulls them out of doing direct care as well. That's a whole new thing that, we didn't have 20, 30, 40 years ago. You didn't have, so many providers. I know so many doctors I worked with that are younger that have gone into weight loss, hormone treatments,
anti-aging
life
practice.
coach type,
vascular, they're, hyperbaric beat bowl poop, but
yeah.
And because it's just money and people will pay money for rubbish and for stuff that, and it's easy and they don't have to stress and they don't have like MDS nurses chasing them and they don't have coders chasing them about bills. And, so it's part of the system that is we're not incentivizing the right direction.
No, we're not at all.
And
especially
I'm
with primary care.
I'm with Scott. I worked in Las Vegas, Nevada for a number of years. There's a lot of really famous people, nicest people you ever meet in the world. One of the surgeons I worked sort of with there, he was concierge, cash pay only, and all he did was inguinal hernias. $5,000, I'll do what you want. He didn't have to deal with insurance. He didn't worry about whether or not he may or may not get paid at the right rate and all this other stuff. As soon as I have my $5,000, we'll go to surgery. It was done.
Interesting.
Yeah.
I mean, it's the same with some bariatric surgeons as well, right? That often is a cash pay service. I worked with one of the, I think, most famous, most popular, well-known doctors in the country. I mean, and it was like a machine from 6 a.m. till midnight on days he was in surgery. And he provided excellent, amazing care, very comprehensive. His patients got a manual. They got all kinds of time with his staff. He was less than lovely with the hospital staff. However, that was another picture. But again, he was just making cash. So it's, it just comes down to, are we going to have enough providers to go around to really, and is this like, for me, I think about this and I think that would motivate me to go become a nurse practitioner to do concierge because I do concierge patient advocacy. What I charge is pretty high.
Oh, but no, I think from what I was seeing, people who pay for service, they don't want a nurse practitioner. They want a physician. You're paying to have a physician.
And that goes a lot into the direct.
Answer your calls in the middle of the night. The doctor, not the nurse practitioner.
And that's with concierge a lot. Yep. But direct primary care can be a little bit different. But I have thoughts on nurse practitioners in direct primary care because I think you can get into a whole boatload of issues. And we'll kind of talk about that when we talk about like the models of it, because I think it can get kind of icky. So I'm going to end the poll. 46% of you said you are familiar. 54 said no. So we have a nice even split. Good. We'll go over it really briefly. I had made half of a graphic that was going to put my words into a graphic, and then Philadelphia ate me. So we're going to do it without a graphic. So we'll use our imaginations. Basically, direct primary care and concierge medicine are on the same sort of plane in that you usually pay a fee every month or annually to be able to see a provider who has a much smaller panel, right? So in primary care, you usually have, if you work full-time, thousands, like usually 2,000 to 5,000, depending on how crazy you want to pack your schedule, patients that you see a year. This is how many people you have that you take care of. If you are in direct primary care, usually they cap it at like 1,000, if not lower, like 600, whatever. And you pay a fee every month to be able to get in and see these people. And then they partner with lab companies, with drug distributors, and with imaging companies to get at cost extra things for you. So if you need labs, they go to the lab company and LabCorp or wherever you are, and they say, hey, I'm going to send all of my patients to you. Can we work out a deal? And you will give me cheaper labs. And they do the same with the drug companies. They get them wholesale. And they do the same with imaging. So like MRI, X-ray, things like that, because you are paying them directly. You're not going through insurance for some of these things. Now it does get complicated because direct primary care is mostly, and this is just primary care. Obviously there's all sorts of we had people doing hernias. I've seen direct primary care for podiatry with like feet stuff. It goes all over the place. But if you're looking at primary care, because primary care is my background. And when I had my existential crisis and I said, I hate this. I hate trying to see everyone in 15 minutes and we aren't doing anything. This is not working. They all said, go to direct primary care. And I said, I don't want people to have to pay more already than they already are because they can't even afford it. And so I initially like scoffed at it, but now I'm kind of looking at it again, sort of, because some ways seem to make more sense than others. Sort of. It's kind of a mess. So direct primary care is over here on like the cheaper side. That is ranging from usually like $25 a month to $120-ish a month. So it can be more affordable. Some people charge you more based on like, do you just want physicals? Do you just want like no on call, nothing like that? I saw the median was looking like 50 to 75 a month. And with direct primary care, you would get all your primary care stuff, sick visits, well visits, random like emails. You could text them. You could be like, I have a question on this. So kind of like wrapping up urgent care and all of that in one. You didn't have 24/7 access to them necessarily, but you could email them, you could call them, you could text them, and they would respond to you. You might not get seen immediately and they might not come to your home. But for that fee, you didn't have to pay any extra. So that is kind of the direct primary care side. It's less concierge because you're not paying thousands of dollars a month. You might have to wait a day or whatever to get in. But that model gives you usually like 30 to 60-minute appointment times with people that are usually flexible. Usually you can get in for a same day appointment. You're going to have someone who knows you a lot better, and they're cutting costs by not having to deal with insurance at all, usually in direct primary care. They just take their annual fee and then they have to pay for maybe an office. Some people do house calls. I've seen some that only operate at your house. So they have a little truck, they have a van, and they just drive around and they come to you. You'd probably have an MA or someone to maybe run your office, and the rest of the money you'd be pocketing, right? Because you're not paying for a biller. You're not necessarily having to pay for the top of the line computer system. If you're not having to go through insurance to prove that you're doing all the things, you can save a lot of money and time by not going through all of those, whatever, all the bureaucratic stuff. On the other end of the spectrum, there's concierge medicine. That's like what Adrian was saying, was like thousands of dollars, up to like $10,000, $12,000 a year. Some aren't that expensive. Some are cheaper. And these are the people who are going to come to your house, answer your phone call literally any day of the year at any time and tell you, no, ma'am, even though you've coughed twice, you don't get antibiotics. I think you probably have allergies or maybe even a cold. Like that type of situation, much more catering. They probably, bring you food at your appointment and go above and beyond to make sure you feel like very, very special. Whereas like a direct primary care is probably more like, well, there's your water cup and we might be able to find some graham crackers type of normal office level. A lot of times concierge medicine may take insurance. So you can be paying for concierge medicine just for the convenience of being able to be seen whenever you want. They might come to your house. I've heard of people meeting people in the emergency room to like help them navigate the healthcare system with you, coming to your house to give your son stitches when they fall out of a tree, like that level, but they still bill through insurance and they still bill for every little thing, sometimes in concierge. So they are a little bit different. I would probably focus more on like direct primary care because that's more interesting to me with like, hey, I'm going to pay you $50 a month. You're going to be kind of my doctor or nurse practitioner or PA on retainer. And let's go from there. It is interesting. So on one hand, I get it because I have been that burned out person who's like, I hate this. I can't see my patients. I can't do anything with them. But on the other hand, I'm like, any service is still expensive and a lot of people can't afford it. So when I was looking into this, a lot of people were like, oh, this is very affordable. It's sometimes only $50 a month. But I'm thinking if you have 4 people in your family, that's $200. And not many people have $200 on top of their already existing insurance, because that's the other problem is you still have to have insurance because this is not going to cover your specialists. This is not going to cover the emergency room. This is not going to cover any surgeries. This isn't going to cover other things that you might run into. So you still have to hold some kind of insurance and it can get expensive and it kind of feels very exclusionary to like, it's a good fix for people. I get that, but it is also, it's making this it's making something work within a system, but it's not fixing the system. And then it goes down to the existential crisis of like, what is our role? Is our role to find a situation, like make the situation better? Or is it to go into it and redo it? And those are my thoughts. What do you think ethically, how is this?
I wanted, it's interesting because it's like the concept of us going in to fix something. I don't even think we have access in the door. Honestly, I don't think any of us do. So that's one
Yeah.
issue. There's one issue, right? Even if we're unionized, and I'm a very pro-union person. However, I've had a lot of very heated discussions about my services and my price point. I cater to a very elite. My marketing is over 300,000 household income. Right. And so, I've had discussions about this with people, but at the same time, everybody has to just kind of mind their own bit, the business that pays them. Right. It's like,
Yeah.
you got to mind the business that pays you. And that's what it really comes down to. So everybody, they're right now, I think where we're at in healthcare, especially, I think that this is only going to grow. And it's going to grow, and it's also geographic, right? So there is a niche of this that is going to be in certain geographic areas. You're not going to do this in, the middle of Barstow. You're not, you've got to figure out, okay, where am I going to get 600 people that are going to pay me this much money? And yeah, it could be a lot of really wealthy ranchers and families. And if you get some big families, but I also see where this is also appealing. And I know some corporations that do this is in order to do talent acquisition in the C-suite, they offer this. So the real money is for a clinician to go to corporations, go to IBM, go to, Apple, go to these big companies, oil companies, whatever it is, right? Big corporations, and say, hey, I've got this service, and, you've got XYZ C-suite or executives, and some of it can be remote. So there's the in-person stuff, and then there's the remote options as well. So it is, there's a lot of ethical issues. And the problem is that we always tend to see the ethical issues as falling on our shoulders as the individual, when there are these bigger machines in control, pulling the strings, and all they're worried about is money too.
Yep.
But when we think about money as an individual, oh, well, God, what do you charge $250 an hour? Are you kidding me? Like, who can afford that? Actually, a lot of people can afford it, and they do. So because they want to have help just making decisions. I don't even provide any health care. They just want decision support.
They just want to talk through with someone. I know I've thought of doing that as a NP, like on this, like as a job instead, where I'm like, I'm not going to like tell you what to do, but I will explain your options. And like, when they give you options, we'll talk through it and I'll educate you on it. Like
I retain an NP who does review for me. So I don't even do clinical chart review. I farm that out to an NP. I have somebody who does billing, so if somebody has a billing issue, I don't do that either. So I don't do insurance appeals. I have somebody else who does that. So again, each individual within the healthcare dynamic has to decide what's best for them. Now, are there repercussions to this? Absolutely. But there's repercussions anyways, because we still are in a system where not everybody has access to healthcare. And it's getting worse no matter how much money you have, because it doesn't matter, like Scott and Mr. Woodwife are saying, it's like, working in the ER, working triage, working in these big hospitals, everybody's still waiting in the same line.
And I was going to make the point, it kind of reemphasizes the two-tier system that we have in this country, those that can pay and those that can't. Hi, Rogue.
Hello.
And it is unjust, it is inequitable, but it's what we have.
And
the question
we need to fix it, but I don't know how. I haven't the foggiest idea how to make this better.
Yeah, exactly. I'm emotionally torn about it, because I think we just need to blow up the system and get a better one. However, I see a huge benefit and would definitely consider working within that model, because you have so much more time and you can do what you actually want to. Also, Rogue NP, welcome from the chat to the screen. We're happy to have you. Do you want to introduce yourself really quick?
Hi, everybody. My name's Kara. I go by Rogue NP. I am a brand new nurse practitioner who has listened to us for years. She got me through nurse practitioner school and has really opened my eyes to all the issues that face us as healthcare professionals. So I've been quite chatty in our chat, as you guys have seen, and very happy to meet everyone.
Happy to destroy your dreams any day. Welcome. Glad you're here. Do you have any social medias?
No, I'm working on that.
Okay, perfect. Let me know when you do, and we will put it out in our chat. So yes, that's kind of where we are.
So back to the ethical issue.
Yeah.
the rightness or wrongness of something. So is it wrong for someone to take what they learned in school and market that to more affluent people? Do they have a responsibility to use what they learned in school, in medical school, to help people who are not wealthy? Do they have an ethical issue to, like, I'm not familiar with the legal field, but I know lawyers, a lot of times, of course, they get big hourly fees for their services, but they always have, or often, I guess, what I've heard is have pro bono work. So they always kind of give back a little. And is that an ethical requirement or just something that they do? Is it something that physicians should do? If you work as a concierge, should you also work in a free clinic twice a month, or something like that? I don't think that they're ethically bound to use their skills for any particular population. I think it's more admirable to help people who can't help themselves. But rich people need healthcare too, and if they're going to pay for it, this is a capitalist society, and you pay for, everything's for sale.
Well, and even in other countries, this exists in different forms. Like in countries that have universal healthcare, you can always pay more to have super snappy, like, they even have private hospitals where they'll be like, this is the hospital everyone else can go to, but if you pay for this other thing, like, then you can even go here. And let us know, like Adrienne said, what your thoughts are. I have had, when I initially heard of this, I was very anti it, because I just and I realized later, like, my own problem of I'm so frustrated that no one has healthcare, but it's not fair that like other people can't go and make bank. Cause I knew some people that were going into concierge and they were making like almost $1 million a year. And I was mad. And I was like, why am I mad? Like, cause like you said, Scott, like it's just using your skills and getting paid for it. And it's not their problem. Yeah. It's not their problem that the system is wacky. But like, so like really, and there's like, I liked the other end of the spectrum. Would I do that? Probably not. I don't have the patience for people who want to call me all at weird hours and be like, oh my God, my toe. Like, I don't have the patience for it, but I could do the other one. And I really like it. Like, that's what I want to do, is get to know people. And then I just feel bad because not everyone can afford it.
Maybe if you were getting $1 million a year, you wouldn't mind taking a call in the middle of the night saying my toe hurts. Maybe, there's a price, right?
There is that.
It's like on the job as a nurse, and you're just like, sometimes something comes up and you're like, you know what? They do not pay me enough to do this, to clean up an entire bed full of ish. This patient has just defecated everywhere. They don't pay me enough. And then you move to another place, another hospital, and there's times when I'm like, you know what? They do pay me enough. I'm actually pretty well compensated at this hospital. I will clean up the poo-poo. It's I will hold my nose and I will take my paycheck.
Fine.
Fine. A lot of doctors too. If you're working in a hospital, this is why a lot of doctors have gone to become hospitalists. I know doctors who are like amazing critical care pulmonologists, amazing in their field, and they were like, yeah, I'm going to go be a hospitalist and go make $140,000 a year, and then
schedule, right?
Because they wanted the 12s. They were like, no problem. I will work 15 days in a row, 12-hour shifts, because I will not have to get woken up, because everybody at different stages of their lives has different needs, right? So if you have children, you have different needs. If you've got elderly parents, you have different needs. But I think, in this model, like everything is up for design, right? Like I'm not on call 24/7 to anybody. And I think as well, if you have a partnership set up, then you can balance that out as well. You can still have an on-call panel and have a system. And I think that this is you're going to see this kind of model actually get corporatized. So I'm going to predict we're going to see, Walmart, and we're going to see Amazon getting in this concierge market at some kind of low mid level of like the $200 to $600 a month. I'm just going to predict it. We'll talk again in a year or two about it.
And a lot of them are already doing that. Like Amazon, I know if you work there, part of their benefits are, because when I was looking for virtual, like telehealth nurse practitioner jobs, they were recruiting a ton of people to come and work for them as primary care telehealth people. And that was part of the benefits that you got, was you got access to this like basically a concierge medicine that they paid for
Mhm.
you.
Mhm.
And you did it through this. It wasn't going to be quite as nice because you were still bound pretty closely by appointment times, and your panel would still be gigantic. And it was more like urgent care. Like you wouldn't find one specific provider and stick with them. You would kind of just call in and whoever could see you, which I think works horribly for primary care.
Call center
Exactly.
mentality.
Yeah.
Yeah, it's horrible.
But this would be like a one-on-one type of thing where you would have that relationship. And I totally see why that would be like awesome and valid. And Keisha had asked, where could you find this? Is one place I found to find this in case you guys are interested. It's the Direct Care Primary Care Coalition. And people can go and like, I think register with them. This is somehow like they want to do something. I haven't read that paragraph yet of what they want to do, but I liked it for its search functions. So obviously we have a lot in California, a ton down here, San Francisco, Los Angeles,
Hey, look, there's one in
Philadelphia.
Barstow.
There you go.
There
There
is
you
one.
go.
You look at Southern California, right there in the middle of nowhere. There's one.
There you go.
All
There
those
you go.
Barstow.
Bakersfield, you got one. So you can use this to kind of like help find them. Or I think you could probably, if you were looking to join one, you could go here and find it. So I'll leave that link down below. I'll put it in the chat for now. But
and I think also, you know, a lot of, I mean, maybe your viewers aren't aware, I don't know, but you know how Medicare works or Medicaid works, right? I mean, if you take Medicaid, you take Medicare, that's all you can charge, right? I mean, you're very restricted as to what you can do beyond that. There's some expansion, but again, I think it's also, I just want to say, like, for example, for me, until my job offered UCLA as an option, their health, which was a competitor of ours, it was very hard to find doctors that were accepting new patients in the county I lived in. Again, because I lived in a rather small county of 1 million people wedged between Santa Barbara and LA County. And, you know, so I was like, yippee, I can just go to like a UCLA clinic. And they were amazing. They're dialed in. It was almost like concierge care. They're fabulous. So a lot of times it's just like you can't even get a provider anyways.
Oh, no.
You could have Cadillac health insurance. You still can't find a provider.
Yeah.
But, you know, Liz, you made a comment about Amazon a few minutes ago. Once upon a time, all insurance was offered through your employer.
Yep.
This may be the new form of insurance. Rather than offering you an insurance program, we just have a group of people that you can see.
Yep.
And do away with insurance as it is, and this is the new form.
And it's going to be interesting with what you do for specialists, like what do you do there? Yeah. Years.
Recently, I joined the California Association for Nurse Practitioners, and they have events once a month, and I've met some people, and I met 2 Facebook nurses, and they are the nurses at the Facebook headquarters.
That's cool.
When Facebook employees need healthcare, they go there, and that's
cool.
their doctor, and that's how they provide that. So it may be Amazon, Facebook, some of these others may be going to that model.
Which almost feels like we're stepping backwards, which I don't think is bad necessarily. We're like going more community. We're like going back into like just putting your people in your community. We're like, yes, you work here and you get your healthcare here, and this is all fine. We're all in the same building. Like
until you get that job and you want to take your doctor with you.
Oh, yeah.
You know, that was the whole big thing with Obamacare. Is
that's mildly problematic. Yeah.
Yeah. So if you want to keep the provider at Amazon and you leave Amazon, that's problematic.
Yeah. And another big thing that one of my biggest concerns with this, just as a known thing with nurse practitioners, is I was watching and reading a lot of stuff of direct primary care is great. Family medicine physicians love it because they can do a lot more that they were actually trained to do without having to refer out, because they were trained to do all sorts of stuff, procedures, injections, minor surgeries, like in the office, but you cannot do it in a 15-minute appointment. And even if your office gives you a 30-minute procedure slot, that's not really enough time to chop out someone's toenail, because it takes 30 minutes for the anesthesia to even kick in and to go over the process. And like, that's not something you want to rush. And so they were saying, I actually get to practice my cardiology skills. Like some of them had were doing echoes on their own in their office because they had learned how to do that. And they were doing all these surgical procedures. They were doing ortho injections, because they had an extensive residency that taught them all of these things. And so they hadn't said this at all. This was like a, they had nurse practitioners in their group and all sorts of stuff. So they didn't say this, but in my back of my mind, I was like, I could see how this could become a problem, because I feel like a lot of like nurse practitioners, we learn the basics and then we're either taught, then you have to hand it over to someone else or you have to refer out. And primary care refers out so much right now that you kind of learn how to diagnose something and be like, I think you have heart failure. Here's the step 1, step 2 through 12. We're going to send you somewhere else for, so we don't even need to learn about it. If you are not someone who is very into learning on your own and very, very driven to answer a lot of questions, that could become very expensive then for people doing direct primary care, versus if you go to like a lot of these physician practice with direct primary care, it made sense. And this isn't like bashing nurse practitioners. I am one, but I could see how going to somewhere like there, you would expect them to know a lot, right? Because you don't want to go to a specialist because that is very expensive. You're going to have to go back to your insurance that you also have you're carrying, but maybe it's like, a high deductible thing where it's going to be hundreds and hundreds of dollars and you aren't anywhere near your deductible because this didn't count towards your deductible, all of your time we've spent together. And I could see it being problematic if this becomes something that a lot of new nurse practitioners who have no experience yet want to dive right into. And I'm like, but where are you learning? You know what I mean? You just don't have the breadth yet, I think. And it might be like limiting.
Well, and that's absolutely true. I told you the other day that I've been doing this for a little while, and it's still a full 25 to 33% of all my charts I stick in front of my doctor and I say, what are your thoughts? I need you to see this one. I've already done the diagnostics, got a sonogram. I need you to follow up with her on. So yeah, he sees a lot of my work. And if you're fresh out of school, there's absolutely no way you can be effective enough.
Because you would have to have a pretty broad scope. How do you feel about that, Rogue, since you're new?
Well, I am new, and I'm actually going into a position that's similar to concierge service. I'm going to be working with geriatric patients and seeing them wherever they're at, senior living, long-term care, what have you. My panel is going to be very small as compared to your common provider. And that's also been a thought is, all right, I'm new. I have absolutely no idea what I'm doing. What are my resources going to be? And thankfully, I'm working with a company that is nurse practitioner run, nurse practitioner founded, and they're awesome. Very much focused on training and retention. So they are going to be so many resources that I can hand a chart to somebody and say, what do you think about this? So that'll be great. But I don't know. I know insurance companies are starting to do this for geriatric patients, which I think is great because then they don't have to fight to get into a doctor's office for chronic issues. And when those don't get treated, they end up in the ER, and it's all focused on health in place. But you guys are right. New grads will have a whole different viewpoint if they start jumping into concierge service. And then who do I refer to? Who do I send the specialist to? It'll be a whole new world if this becomes commonplace.
Yep.
Well, that'll be on the nurse practitioner, him or herself, to make sure that you've got supervision. You know, because you're taking a risk by not. If you're saying, "Hey, I'm out of school, I can do whatever. I can handle everything," you're taking a big risk and you're out of scope because anything that you don't have education and experience for is technically out of scope. So you have to make sure. I mean, I don't know who it's going to be or where it's going to be yet, but I'm going to be damn sure that I have a doctor in my back pocket.
Absolutely.
And that doesn't mean I'm less of whatever I am.
No.
It just means that I have
You're
that
smart.
backup. And it's also a way for me to keep learning, right? I mean, that's the way it was in the ER. As just an ER nurse, I always had a doctor right there. Unlike other places in the hospital, I always had a doctor nearby. So if I said, "Hey, what's going on with this patient? I know they came in and you ordered this and that. Why'd you order this?" Or, to me, it looked like a stroke, but you say it's a migraine. Why is that? It's like, oh, I didn't realize there's that type of migraine that has, anyway. So it's a way of continuing to learn and grow. Even at my next level, it will be.
And that's precisely why I am of the opinion that any, let's say mid-level, a lot of people don't like that term, any mid-level provider who doesn't have a physician on hand is insane. Absolutely insane. You need to have someone to ask a question
Mhm.
ask a question to, put a chart in front of, get a second opinion. Just look at this with me. Anything. I just need someone
Mhm.
else's eyes on it.
Mhm.
So,
Yeah.
Chad, are you against any form of independent practice for
I'm all for
like a nurse
independent practice.
practitioner?
No, I'm all for independent practice, but you better have somebody in your pocket that you can
Mm.
ask a question to.
Mhm.
And
Yeah.
don't get crazy. Know what you don't know.
Yeah.
Know
That's the
when you're at
hallmark. That's a
know when-
hallmark of a professional, is knowing what they don't know, knowing their
Yep.
limits, and saying, I don't know, but I'll find someone who did, or I'm going to get you the care you need if I don't
Yep.
know. I'm not going to try to fake it. I'm
That's
going to say, no.
absolutely right. You have to
Mhm.
know when you've reached the outer limits of your knowledge and be able. I've looked at patients and say, I don't know. I need to go ask my doctor. Let me go get him. And I
Mhm.
bring the doctor back and he does the exam with me and he says, I think it's this. I
Okay.
didn't see that. You're right. I didn't see that.
But you might see it the
Yeah.
next time.
Yeah.
I will.
Because you didn't, kill yourself during residency.
Right.
See all the 8 million things. And Michaela S said, maybe it'll come down to NP and PA residency programs where they're doing a residency program before they're allowed to do this type of medicine. It'll be interesting to see how they do it. And like, since it's not tied with insurance, it'll be interesting to see how that's regulated. But I personally think that if you want, and this is off topic, but if you want independent practice as an NP, you should pass the exam that physicians take as a family medicine specialist. And if you can pass their board exam or whatever specialty you're in, then you can practice independently. And until then, you cannot.
Problem
that's
with
probably going to take a
residency
while.
programs.
Mhm.
Sorry. Problem with
No.
residency programs is there's so few placements. I've checked
Yep.
out residency
Mhm.
programs all in the Pacific Northwest. You probably have 3 to 10 placements annually for
Yep.
hundreds of nurse practitioners to get into. So the continuing education to transition from RN to NP is really on the nurse to find a
Mhm.
mentor and a guide, because the
Yep.
programs just can't cut it.
Well,
Yep.
and if it goes any further down this road, it's going to put some of the onus back on the schools to do
Mhm.
better education, do more clinical hours, different clinical hours. It's going to, and it'll also put the onus on the board of, like the midwifery board and the family practice board, the certifying agencies, to make sure that you have enough required clinical hours in each little area.
Yep. Yep. Deb Trilly said, my PCP did this, switched to direct primary care. He was our doctor for over a decade and we had to leave his practice and it was difficult to find a new PCP, which is frustrating in itself. And I saw a lot of that too when I was looking through this, because a lot of times what people do is they have a private practice and all of a sudden they just decide, hey, I'm not going to do this model anymore. I'm going to cut down, call all their patients and say, before I had 2,000 patients, I'm going to go down to 800. This is the price per month. Do you want to be one of those people? And if you don't, then you have to find someone else. And it is hard to find people. There were no pediatricians. I live outside of Philadelphia, so it's not a small area. There were no pediatricians within a 75-mile radius that were accepting patients with my health insurance for a pediatrician. So they're coming to my family practice office and it took them 5 months to get in to have an appointment. And they only accepted them because I was already a patient and I begged. So this is a problem because everyone's running away from the system we have right now because it is so heart destroying. You go in it because you like people. You're like, I want to be your primary care provider and teach you about your body. And then they're like, here's 15 minutes. And you're like, what?
Well, maybe that's the ethical issue, is that situation like the one I saw the story on, where you already have a panel of patients. Now, those people you do have a duty to. And for you just to say, hey, I'm giving you fair notice, find a doctor or sign up. I mean, my doctor moved, did he stop practice or move to a different county or something like that? But he arranged for at least this one population of patients to be taken over by this other doctor. He's like, if you don't want to go to her, you don't have to, but I'm arranging for you guys to go to her because I'm going to Daly City.
Yeah.
And she's amazing, by the way. So I don't pay for concierge medicine or anything like that, but I feel like I get it. I think I lived a charmed life. You already know this, right? I haven't had to deliver a baby in an elevator. I have nurse patient ratios. I've always been, I haven't been like assaulted,
We have a California boy over here.
Yeah. I mean, well, wasn't always, but
That's true.
Another way I guess I'm living a charm life is my doctor works with a lot of residents, and she sees her own patients, so she has more flexibility in her time. And my first visit with her, when I did get transferred over, was 2 hours long. And now every time I go to see her, it's at least an hour. And she's like, "Where are the doggies? Why didn't you bring the doggies? I want to see the doggies." And so sometimes
what the heck?
And he asks about school and how my family's going, and yeah. And so if that's what you get when you pay for concierge service, I can see why some people would need it. And I have her, like all the stuff you were saying, I can email her through the system that we have. She'll email me back. I can't call her in the middle of the night, but I get responses back pretty quickly with that. I need a prescription. Of course, I'm also a nurse. And so, I mean, I'm kind of on the inside. And when I ask for something, it's specific. So, it's a little bit different, but I can see the draw. Let's just put it that way. Of that kind of access and attention.
Well,
but
for
patients, you have a duty to the patients you already have. And I think to just cut them loose, there is an ethical issue there.
And you can, because like Deb said, it was devastating and I felt kicked out. And how could you not? You know what I mean? It's kind of like putting a price on your head. But you can. All you have to give patients, I think, is usually your insurance dictates what it is. I think Medicaid is 90 days that you have to say, hey, you have to find somebody else. And that would feel horrible, especially after a decade. Like, some people do think it's cheaper. I think it depends on how cheap the service is. Concierge is never going to be cheaper because concierge is always going to be expensive. If you are in the office a lot, and if you're using imaging and labs a lot and you're getting it at a super big discount because they're asking you just to pay cost, it might be cheaper. Like it very well might be, but for a lot of people, it's going to be an additional cost on top of what they already pay, which kind of stinks.
Maybe one of the legislative issues that was on that page, I didn't read it either, is maybe getting it so that the money you do spend on concierge medicine counts towards your deductible.
That would be cool.
Yeah.
But then they would have to go back and look at how is it regulated. And then you would just go back into like, they would want to see your documentation and your yada yada, which is, I think, a lot of the benefit of not doing it that way. Right. I'm not going to take insurance. Which in case you aren't familiar, insurance dictates a lot of what we have to do in primary care. They say, hey, you have to chart this. You have to ask every patient who walks through the door if they're depressed, when the last time their colon cancer screening, when did they have a whatever, when did X, Y, and Z happen? And when you're documenting, if you want to document that they need this medicine, you have to write X, Y, and Z. You better have this code. Like they ask for all of that. So I'm assuming your notes would look a lot different. You would just have to be able to justify what you're doing in front of a board if you ever got sued, to be like, hey, this was my thought process, but you're not having to worry about all of that other stuff. But if it was going to count towards your deductible, I'm wondering if they would make it then you would have to go all the way backwards and look at that again.
Well, I mean, they've got those medical savings plans that are legal. You put money away pre-tax, yada, yada, yada. It could go, that could be tied in directly with that, with just one more sentence in the law.
But those healthcare spending accounts, I bet that can be used for this type of thing because it's healthcare.
Yeah.
I would imagine that's okay. I mean, if you can use those
you would think so.
Over-the-counter medications and things like that, I don't see why.
And this sounds like a mess. He was going to use our insurance and charge $1,600 a year. And so then at that point, it's like, what's the point? You know what I mean? Like, why? If you're using my insurance anyway.
Still have a deductible.
Yeah. Is it so that I can get in faster? You know what I mean? Like, because right now it's hard to get same days appointments. Like,
that is true.
Don't know. Don't get it. But then that comes down like,
need a same day appointment either. It is a convenience. Sometimes there's a medical reason. Look, we need to see you within a couple of days because if we go longer, the infection's going to get worse. But sometimes, you don't need to be seen the same day necessarily. So you're paying for convenience, and that's the American way, right?
But as a provider, no, you don't need to be seen the same day. As a patient, I want to be seen yesterday. Right. Patients are very insistent. They need to, their kid sneezed twice in the same hour, and he's dying of cancer. I know he is. You got to see him right now.
But what we fail to do is educate the public about how healthcare is different from other industries. I used to get so mad because people would come. I work triage a lot in the emergency room. People would be there and they'd have to wait. And then they'd say, hey, I just saw that person go back and I got here before they did. And I'm like, okay, this isn't Burger King. You don't line up. There's a whole different process here. But people, and I got so angry. And then I realized in every other place that those people go, it's first come, first served. At the grocery store, at the Burger King, at the DMV. So they get here and we're telling them, no, if you're sicker, you get to go ahead of the line. That just messes with their whole sense of what's fair in life.
Yep.
And we have yet to, and just because they want to be seen right now, it doesn't mean and that's the whole thing about, this may be another tangent too, about patient satisfaction in the ER. We want to have really high patient satisfaction. It's like, well, you know what? We can't give everybody what they want, because sometimes what they want isn't good for them, or it's not reasonable. Drug seekers come in wanting drugs. If we give it to them, we'll get a high score from them, but it's the wrong thing to do. So sometimes as people in healthcare, we can't give people what they want. And sometimes what they think they need, they don't need necessarily. And it's, I guess, incumbent upon us to educate them about that. But it's difficult in some,
and there's a huge flip side to it too. Because yes, people try to come in all the time for colds or things where you're like, this doesn't matter. And then we have other people saying, like, with the patient wanting it, like, too, like we have persistent tonsillitis that we can't see until December 7th. That's months out. Like Mel said, often things are really urgent. You get told 4 to 8 weeks out. So in that case, it could be super beneficial to have a way to be able to be seen quickly.
Not necessarily the same day though.
Exactly.
Yeah.
So like, it's just kind of, it's a mess.
And part of that immediacy goes back to what you see on TV.
Mm-hmm.
10 times a day, you see pharmaceutical companies pick any one of them. You got this problem, we've got this pill, and I can cure your whatever. Fill in the blank here.
Dry eye.
Mm-hmm.
I can cure schizophrenia with this one medication, and all you got to do is take it. Well, they
Mm-hmm.
so it's an immediate effect. Well, that's a lie. B, nobody gets in that fast, and so, but they're sold that lie on TV. We can fix you today. Just get this.
Yep.
Who
And
knew
yeah,
we needed a prescription medication for dry eye? Who knew?
now you do. Someone I know is going to be working as a provider that just does same day appointments because they don't have enough room for other providers' schedules. Yeah. A lot of healthcare offices are actually doing that too, where they'll have like an urgent care side of the hallway and they'll just have all same day appointments over there. And people they hire people like specifically for that. I was at one time going to go work at my OBGYN doing that for them as an NP, like same day GYN things that did not involve babies.
Educate me a little bit. I thought a lot of these primary practices kept a slot or two open every day for same days.
Some do. Some don't. We at our office, we had no room for same days. So like if you had we just didn't have enough spots, like, because, and that kind of depends on how your office is managed, but we had a huge population of people who were seen all the time because they had a ton going on and we just didn't have any spots open. And so,
and even if you do have same day appointments on your schedule, they're filled by 8:15 in the morning.
Mm-hmm.
Yeah.
They're taken, so they're gone.
Mm-hmm.
I just came from a clinical where I was working, and they were hiring nurse practitioners to work a hybrid model where part of their day would be spent helping the providers clear their in baskets, their prescriptions and everything else. But they also had like a quarter of the panel size because half of their day was same day appointments or follow-ups or what have you. And so the pay range on that was ridiculous how small it was because you didn't have your own panel and they wanted
that sounds
you
like
to use
a terrible job.
Yeah.
Like just do because the only part I liked about my job was the people, and I hated that other part. And Clayton had an interesting point, just as a good teaching point for all of us, because I know I've said this word a lot. I really don't like the word drug seeker. As a chronic pain patient, that's their meds, they're prescribed and do everything I'm supposed to, and not a drug seeker, but deal with flares, and had been called that. Love you, Scott, just saying, just bringing awareness to it, which I appreciate because I say that too.
Yeah,
That's probably a good
thanks
perspective
for
to look
pointing
at.
that out. Because there are chronic pain. I am a chronic pain patient, and that's one of the things I struggle with when I have to go to the ER, which thank goodness isn't often. But I was in there a couple of months ago, and I'm like, how do I express what I need without looking like a drug seeker? Because technically I am seeking drugs. That's what I would like to get today. But I'm talking about people who are addicted, who are abusing medications, that are doctor hopping and doctor shopping and use the ER as one of their stops. So,
yeah,
but
and I don't know of a different way to say that.
Chronic pain patient.
Yeah.
Absolutely, I was not talking about chronic pain patients, especially since I am one.
Yeah, and Keisha's right. It does. Yeah. So if anyone knows of a way that's better to say that, let us know, because that's what we're all about here for, is to learn how to say it. We all like, and to be totally transparent, that's usually just what the terminology that we use in the hospital is.
But there's also
seeking. But I totally see that it's like not great.
There is front of the house talk and back of the house talk in healthcare. So there's things we say back of the house, terms we use that we would never use in front of a patient. So,
which doesn't mean that we can't change it anyway, because that's probably slightly influencing the way we see it.
But drug seeker is one of those that's both front and back of the house. That's not like a secret term that we use for the particular patient population.
So let us know.
Clayton, how do you want to say that? What's a better way? Let us know.
Keisha said, Rogue, it sounds like that's a glorified secretary. It like, that sounds terrible. If you're ever getting an NP job and they tell you they want you to primarily help them with charts and doing things like that, and you have to room your own patient and doing these things, the answer is no. Just no. Okay. I have had friends that went to interviews like that. They're like, well, you're just going to like help me scribe and like write my notes. And they were like, that's a scribe. Like,
actually, there's a major cancer center up here in Washington that if you get hired on as an NP, they make it sound like you're going to have your own panel, you're going to be your own provider, but the NPs are just scribes. They're literally just in there with the doctor, typing everything out while the doctor's going through it with the patient. And I'm just like, you're paying this person X amount of money. You could just have somebody come in and do that for a quarter of the cost.
You get pre-med students to do that. They love that.
Yeah. Yeah. Yikers.
Seriously, that's who we employed, I think, at the last hospital.
Yeah. That's a mess. All right. So would you do direct primary care? Panel. Would you in the office go do that or be a patient in direct primary care? Let's say it was going to be $100 a month for everyone in your family. Would you do it?
Well, I've got 6 kids, so no.
Yeah. Yep.
I'd be broke.
That's a big no. I wouldn't, because I'm in the fortunate position that I don't use primary care a lot. I use like psychiatrists and other like therapy type things. So it wouldn't benefit me because I literally go to my PCP once a year, and that I wouldn't want them to take over my more complex brain things. That makes me nervous. Like, so I wouldn't do it, but I would maybe do it.
What if your psychiatrist did that? Had a small panel with a paper service for access and I don't know, cheaper.
No, because I don't need to see them enough. Like maybe if I needed it more, like maybe if they could do it like per month, like that would be cool if you were in a new transition phase to a new medicine or something, and you would have access to them more often to be like, hey, this isn't working, or like, until we figure this out, I will pay for this. And then I'd just like to go into your regular queue. Like that would be interesting, because that would be something that I would consider paying more for. But I like the model in terms of working in it. Like I would consider, if I ever go back to practicing again, working in some kind of a direct care model where the price point wasn't insane and it was for normal people, because I like spending time with people.
I think there are benefits to concierge service, especially if you're talking people who are working 2-3 jobs, or their job is very demanding and they just don't have the time to see their provider during normal business hours. It could be something to look into, because a lot of times health just falls by the wayside for those people, because it's like, it's my health. I can't feel it. It's not affecting me. C'est la vie. Or for people who have chronic issues, who maybe they have gout flare-ups a couple of times a year, and they just want someone to come in, prescribe them like indomethacin or something like that, that they don't have to go and wait 2 or 3 days to see a provider or go to urgent care. They just call their person and say, hey, I've got a flare-up. Can you please prescribe this for me?
Well, that's what Doctor on Demand will do.
Yep.
I think that's the place for that sort of thing.
Mm-hmm. And this would
that's
just
a
be
brand,
someone
that's
who's
a brand
more,
name.
yeah.
I mean, and any of those services, not just that brand.
Yeah.
I wonder what the cost difference would be between a concierge if it was like Liz said, $100 a month for somebody on demand versus the doctors on demand.
I think doctors on demand is usually about 30 or 40 bucks a pop. So if you were seeing them 3 times a month, it would be cheaper
like
to just do a.
I
I think it depends maybe with if you have insurance, like what it works out. Like my insurance prioritizes doctors on demand because they don't want you to go to urgent care.
Yeah.
So my doctors on demand is like $15 or something when I use that.
Mine does Teledoc and it's free actually.
Oh, that's awesome. Yeah. My
But
old
I don't
insurance
use it. I
didn't do
asked
any
my
of this.
doctor, I said, since I have such access to you, what would be the appropriate? I just got a letter saying I have access to this through my insurance. And she said, I don't know, because you can always call us if you need something. So, I mean, there's a couple of times I needed like an antibiotic or something like sooner than later. And so that was good. But I also have a pain contract with my doctor.
Yeah.
She's the only one
so
I
then
can
you're,
buy my narcotics from. So I
Yeah.
can't be going to them and asking them for it because it's
and then like Renee said, I have doctor on demand with my insurance with no copay. So that's great. And primary care, we actually hate this because then you only ever, it goes back to the problem of if you do have 6 spots, people will only obviously want to do doctor on demand, especially if you don't do telehealth at your office. And then I never see you when you're sick and I have no idea what's going on with you. So then when you come in, I'm like, and then you might not tell me, which isn't your fault. Like you just kind of forget that you've done this. And all of a sudden, like later you're like, I've had a sinus infection 12 times this year. And I'm like, no, you haven't. Like, what are you talking about? They're like, oh yeah, I did doctor on demand. And they always just sent me antibiotics. And I'm like, wait, what? Like
that messes up continuity of care for sure.
Exactly.
If you're getting an ultrasound from here and a diagnostic from there and blood work from someplace else.
Yep.
And it never all falls back to the one spot. I don't see it all. I'm missing pieces of the puzzle.
But as a patient, I'm the person who uses it. Like when I got horrible poison ivy, that's what I was using because I was like, you don't have telehealth. I have children. I'm not leaving my house with them. I barely want to get out of my bed. Like, and it's cheaper for me to go see Teledoc than to see you in the office.
So if we could get those Teledoc. If those Teledoc companies would then communicate with your private doctor, if part of that would be, who is your private doctor? We're going to send a report to them as well. Or have your primary doctor say, hey, anytime you use one of those services, would you call the office or email us and let us know what went down so that we don't have that kind of discontinuity of care. Your question about would you work in that? The reason I'm going into this for the same reason that you are, I want to sit in a room with a patient, examine them, talk to them, teach them, help them live healthier lives. I don't want to do paperwork. I don't want to do social work. I don't, and people are like, primary care is social work. I'm like, don't tell me that. And if I had more time to do it under a direct primary care model, I might want to. But one of the things I really prided myself on as an emergency nurse all these years is that it doesn't matter who you were. When you came in our doors, you could be the bum on the street or the president of the United States, and you were going to get excellent care. We were going to take you seriously and do what we could for you. And being in that model, I would be excluding people that couldn't afford to come see me or see us, I guess. I'll be supervised, to come see us. And granted, they have other people they can go see, but I don't know. I might be one of those guys that does that and then do the free clinic once a month.
Or if you're making enough money doing it the other way, you can occasionally take somebody who's indigent or can't pay and say, you know what, this one's on the house.
And it's a tax write-off.
Yeah, or just conveniently forget
That's why,
to bill them.
That's why, like we were talking earlier, those lawyers do that is because if you do enough pro bono stuff, you can write that off as you can bill it your hourly rate and say, hey, I did this for a charitable cause. That's why they do it. Yeah. And Natasha said that currently work as an NP and do house calls. And this is actually this would be so cool. I think if we moved more towards a primary care model that went to people and met them in your community, like where they're at. So you didn't have to travel crazy far, but you could go and actually meet them where they don't have to leave their house with their 2 kids who are screaming or deal with all of the oh yeah, that's fine. I will come to you or I will come to your office in my town where we're local, where I know what your resources are because we all live in the same place and I can actually get familiar with my one town versus the 12 towns around me. Like, let me come to you, make it easier. I can see your house. For our older people, you could go through and be like, let's look through your kitchen and what are you actually eating? Like, how could we actually make this work better? Oh, I understand how your exercise, like what we could do to get you moving. We can't have you walk because you don't have a road outside of your house, or you don't have a sidewalk. But look, you have this. We could go do this. Like, I think that could be epic. And that's a dream. That would be, I think, super cool.
And Rogue, what did you call it? Health in place? Is that what wasn't that the term you used? Health in place? About
Oh yeah. That's cool.
I like that.
Yeah.
I know somebody else in the comments earlier was like, we're going back to a little house on the prairie where the doctor just makes house calls.
Exactly.
All around the town.
Exactly. That's why I was like, are we going back to house calls? Because I honestly don't hate it.
And he's also your vet, I think is what they said to you.
Doc Baker was a vet, yes.
Yep.
Well, I did house calls when I worked hospice and home health, and it was amazing just to meet patients where they needed me to meet them and not make them come to us. And you could see so much more about their living situation and their family life, and see how their chronic diseases were impacting their whole life, not just the pretty picture they paint when they come into the doctor's office and say, here it is.
And they're more comfortable. People over telehealth told me so many more things while they were sitting there, like stress petting their cat or their dog. Like, they told me things that I had known them for years already. And then all of a sudden they're saying, I'm like, what? And they're like, yeah, like I just never felt comfortable sharing that. And now, like, blah, 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 blah. I was like, oh my gosh.
In the comfort of their own home. Yeah. Then you're just like, okay, I'm relaxed. I'll tell you what you want to know.
Yeah.
I'm not really sure I could do what I do at your house.
Why not? Come on. Come in with your suit on. Wear like a wetsuit. Get some goggles.
some kind of portable stirrups.
Walk in with your flippers and be like, I'm ready.
What
Here
do you
we
think
go.
He does, Liz?
Goodness.
How do you envision his job exactly?
Clearly, you've never had a very messy birth.
She's done what I've done.
I've seen some things.
I'm the one who doesn't understand. I get it.
I don't know. All I remember is after Avery was born, everyone said I was in the splash zone, and I was like, I don't want to hear any more about any of that. Please no. And my nurse came back wearing different clothes, and I was like, oh dear. I'm so sorry.
True story. True story.
Avery was stuck. She came out like this. So when she popped out finally, it was like there's your TMI of the day. Yep. Wetsuit.
Let that sink in.
Yeah.
Scott, when you get to your GYN clinicals, come visit me.
Yeah.
I'll walk you through some of it.
You know, it's funny because as a gay man, I have very little experience with that body system. Certainly not socially. And in the emergency department, when the docs do pelvics, they don't call us to come chaperone.
Well, and it's not normal for it to be a splash zone, Scott. We should clarify this.
Okay.
It is. That is not a typical. Usually.
And anytime I do a catheterization, I do it on an elderly patient. So the only ones of those I see are like really old ones. And I'm actually kind of looking forward to that rotation because it's something I have a lot to learn. And I understand it's important to give primary care to women. They have body parts that need attention. And if I'm going to do FNP, that's going to be part of the population. So I might be calling you with some questions. Absolutely.
Please do.
You got my phone number.
I'm not. You might think, ew, I don't want to. Yeah, I'm actually kind of looking forward to it.
Yeah.
For now,
I think.
Ask me in a year.
And I think you have a very like genuine approach. You know what I mean? Like some people just make you feel uncomfortable. I feel like you are very like disarming. You know, I mean, like or whatever it is when you like make people feel comfortable. And I've always said that my male providers have given better pap smears because they are terrified of it. They don't have that organ, so they are unsure. Like they are so gentle versus women, and they're like, "You can take this, and I know it." And you're like, "Ah!"
I am scared to death to hurt a patient.
Exactly,
Scared to death.
But let me know, Scott. I have speculums that I'll show you how I teach all my students to.
Okay.
I was going to say, Liz, in the same respect, does that mean women give better prostate exams?
Oh God, do we have to go down this road?
Sorry, it popped in my head.
I very much utilize my friends at urology when my patients had questions about that.
You want to go down this road. Men make such a big deal out of the prostate exams. Okay, it's not comfortable, but it's not painful. It's something it's a sensation you're not used to for most men. Don't be a baby, for crying out loud.
That is true. You do have a point there.
Shut up. Oh,
you have a point.
Yeah.
You know, some things we do are painful. Some things we do are painful, and we try to make them less painful with numbing you up and all that kind of stuff. But sometimes, or just very, very uncomfortable, like putting a nasogastric tube in. Mm-hmm. I don't care how much lidocaine jelly you use. Everybody hates that. Even swabbing their nose for a flu swab, sticking that swab way back in their brain. But it's quick. It's not that bad. I don't know. Just it's a psychological thing for a lot of people, I suppose.
Very off topic, but it just might make you smile. I had when I was in NP school, there was also a med student that was like in one of the same clinics that we were doing something in. And there was a very kind woman who had she was coming in for a PAP, and she'd had tons of kids. So she always I guess was known for allowing students. And the student went in and had said that they were very comfortable doing these procedures, so that's fine. And they went in and they came out and they were like, I did it. It was fine. We have the sample. And I also did a prostate exam. And that left.
Oh my holy God.
So many they're like, I couldn't find it. So I think it's small enough that it's not a problem.
Oh. You know where it is? It's at home with her husband. That's why you keep
Her husband's taking care of it right now.
Yeah, he has the prostate for the day. Oh my God, I love that story.
That makes me hurt. It just makes me hurt.
Yep. Typically, you don't have the need for a pap smear and a prostate exam at the same time, in case you're confused.
I do tell my fathers in the delivery room that if they hit the deck, they see the blood, they hit the deck, we will do a cervical exam on them. So don't.
That is so mean.
So don't hit the deck.
Yes. Slightly more back on topic. Kiana had a good, for people who are homebound, who are disabled, chronic health issues, or immune deficiency, home visits, vaccines, and blood work are important. Absolutely. And I just think it's more, I don't know, more of what you actually need in terms of primary care. I think we really, really clinicalize, a lot of obstetric type of care and primary care, when that could really be a lot more laid back and chill, because we don't need all the crazy stuff a lot.
I really like what you said about the home evaluation too, the home assessment, because how much can that tell you about that patient and what they have access to and what they're actually eating? Can we look in your refrigerator?
I did that on telehealth all the time. I was like, let's go on a walk to your refrigerator, friend.
That can also be frustrating, because in the small community I'm in, there's not a whole lot of resources. So even if I know that you don't have much food in the refrigerator, I have nowhere to send you. I have no resources to give you. I can't do anything about it. And to me, that just makes me sad and frustrates me.
Yeah.
I guess I was thinking about what types of foods, not how much.
Well, but then then as a provider, you feel like, okay, I'm going to go buy this person some groceries. But then you got 10 people having the same situation. And before you know it, you're broke. Your refrigerator's empty and theirs are full. So.
And we talked a lot about new nurses and student nurses and setting professional boundaries. And there are times when you're like, I want to buy this patient lunch. I want to buy them a bus ticket. I want to, give them money in my own pocket, that kind of thing. And that's a beautiful, beautiful sentiment. But if you, and it's not true that if you do it for one, you have to do it for everybody. It's a kind act for that one person, but you start to blur the lines, and maybe you can afford a bus ticket for that patient, or, a bus token, whatever, but it starts to blur the lines. And I think I'm not usually a slippery slope kind of guy, but it's part of those boundaries. But we all have those feelings that we want to help. That's why we're doing what we do.
Yeah.
Well, I remember a situation a number of years back. I was in a home health situation, and the gentleman was saying that he couldn't afford food. He kept calling in and saying, I have no food. I've got no food. And so went to go do a home evaluation, and turns out this poor gentleman, all his money was being sucked away by vitamin companies. His cupboards, his closets in his house had vitamins out the wazoo.
Oh my gosh, the vitamins.
We had to do an intervention and called the family and said, how much money is he spending on this every month? Thousands of dollars on vitamins, just subscriptions. And so if we hadn't been in the home and seen it, because the family was out of state, we wouldn't have known why he was having financial issues.
Wow.
And those prey on people, especially like that, like crazy. I can't even tell you how many people would come in and they're like, I can't afford any of this. And we're like trying to figure it out how. And they're like, but I'm taking all these 12 million supplements. And I'm like, sweet baby, please stop.
That is going to be one of my missions, is to disavow people that notion that you need all these vitamins and supplements and that you can detox. Dear viewers, let me tell you, there's no such thing as detox. That's why you have a liver and kidneys, and you don't need vitamins for the most part. Check with your doctor to see if you actually have a deficiency, but most people don't. Only about 25% of people do. So, and those pills don't make you have better memory, and they don't give you bigger muscles, and very few of them make you better in bed.
Well,
some of them do.
It sounds like you know something that maybe you need to share with the classroom.
The over-the-counter pills for that. Some of the over-the-counter pills have ingredients that will do that, but it's unregulated, and you don't know what you're getting. And they're
is that for a Tuesday night chat, Scott? Is that a Tuesday night episode that we should have?
Maybe, yeah. You know, let me know.
The Tuesday, late night episode.
Everybody's
supplement you really need. Yep.
There we go.
The truth about Scott.
Late night Liz after hours.
And for that, we will have to have a note from your mom saying she will not watch. Be like, I solemnly swear I will tune out.
Okay.
I will not.
Well, Scott, some people don't need a detox, but some people do. If you're eating plutonium on a regular basis, you should probably detox.
Okay. I mean, if you're eating plutonium on a regular basis, how long are you going to live to need a detox?
Well, depends.
Some people are probably going to try to find out. They're like, let's see about this.
It really makes me mad that there are those ads on TV. I made a video about this, but I dare not publish it because I'm afraid of getting...
Do publish it.
Oh, you know, maybe I'll do it unlisted and I'll let you guys watch, you watch it. But I review the commercials on like 3 of these big things that I see on TV, and I just rage every time I see it. So making that video was very therapeutic for me. But I also had read a really great book about influence and all the tactics you can use to change people's minds. Gift giving, when you offer a free gift with purchase, people feel like, well, you've given me something. I feel like I owe you. All these things, the bandwagon effect. 30 million people have lost weight with our pill. It's like, come on, be one of these people. And I go through and just the one with the belly fat, where there's a barrier to the belly fat, and I'm like, that's not anatomical. There's no barrier to belly fat, and there's no spot anyway.
And they're really disappointed when they find out how that works. I'm like, the diarrhea you will experience,
regulated. And it's not regulated. The public doesn't quite understand that the little things has not been evaluated by the FDA. These claims have not been, substantiated. They don't know the difference, and I just feel like I feel bad.
That was my comment earlier about you can watch 10 things a day on TV about if you just take this pill, and it's just not how it works.
Well, it's not just TV anymore; it's social influence. I mean, the detox teas and the pills and all this stuff. You see it on social media, and it's just blaring at you all the time. And once you sit there for 5 seconds looking at it, it's like, oh, I think you're interested in this. I'm going to send you 20 more things exactly on this topic. It's like, oh my God.
Yep. And I'm not like anti if people want to take like a little bit of turmeric or whatever. Like I'm talking like the crazy supplements when you go down a wild, those are pretty affordable at most places. Some like they have some clinical benefit. Maybe sometimes this is like when people pull out their like chest and they're like, I take this every day. And you're like, oh dear. I found this yellow strip on the internet, and my sister Susan told me that if I took one of these every day.
Oh, remember those little pads you were supposed to put on the bottom of your feet, and they're supposed to suck out the toxins? You brought it, and it was all black, and you're like, see all the toxins that got out of your body through your foot?
No, it's because you didn't wash your feet for the last 3 days.
It's like
Take a bath.
Yep.
It's like a tax on stupid people.
Mm-hmm. And Allison, this is a good point too. Oh, go for it. Yeah. Bad foods are cheap and good foods are not. Exactly. For healthcare to be most efficient, that needs to be changed. Many people can't afford to eat healthy foods. Yes. I think we need to do a huge education. This is going to be part of our high school course when we roll it out of how food works and how and yes, what you can just, I don't know. Why don't we spend money on that in terms of like government funded things of like making healthy food accessible, teaching people how to make easy, cheap, quick. What I would really like to see is a cafeteria come to all towns and they just make healthy foods and you could just go and pick up your daily allotment of not necessarily like delicious, but like healthy food so that I don't have to make it because I hate it and I'll pay you. Like
ding dongs versus broccoli.
I'll pay you. I will do this. That seems like
kind of like those meal delivery services because I've thought about that. I really don't like to cook.
We've done. I actually really like those. I've done. Not Green Chef, Fresh, something Fresh, whatever it was.
HelloFresh.
HelloFresh. We used to do that when I had a nurse practitioner job and made a little bit more money. And we did it because it was we both hate cooking, hate it. And I have such decision fatigue that like deciding what to cook, we both hate it. So we paid the extra, we just did it and I loved it.
That's one of the great things I loved about being in college, living in the dorms with a meal plan. On the mornings that I didn't have a morning class, I got up and went down and had breakfast and went back to bed just because it was free and someone was cooking me eggs. I mean, it was great. I wish I could get a meal plan now.
I grew up in not so great circumstances where food was not always readily available and not healthy at all. And growing up, I've done so many research projects about food and like food deserts and everything like that and how that can be a thing in our country. And I would love, because I've seen all of these initiatives where it's, hey, bring food to the family at home. And it's like, that doesn't always work. I've seen food get traded off for things it's not supposed to. My thought has always been, why can't children from a certain age to a certain age go to a community cafeteria where they can get 3 square meals a day for free? If we're going to put our money into funding, put it in a place where it's guaranteed that this is going to be the result. Then parents don't have to worry about their children getting food. They have to worry about themselves.
Well, aren't the school lunch programs, isn't that like 2/3 of your plan is having breakfast and lunch at school? Well, not 2/3, 2/3 during the school year and then
during the school year.
Sometimes they do things too.
But that's if you can get on the programs.
Even some of the school districts I've been in the last couple of years, all summer long, all year long, no proof of residency. If your kid's under 18, they eat 2 meals a day, period. And it's I don't know if it's state funded or federally subsidized or what, but
that's awesome.
365 days a year, 18 and under, you can eat twice
that's
a day.
Awesome.
So it's not the best food. My kids didn't always like it,
but it's there.
It's something.
If I give them a couple of bucks each time I go in, can I eat there too?
Just go in on your knees. Walk in on your knees.
I don't think that's going to hide all the gray.
No, I was going to say the beard may be problematic.
I have a pituitary disorder. Okay.
Go back to the masks.
Yeah.
There you go.
There you go.
Or shave it all off. Don't men lose like 20 years when they shave off their beards?
I don't know. I think I was going to say I like you with a beard, Scott. I think it's very like distinguished, and I think a beard suits you well.
Thank you.
Rachel said we veered off into unknown territory. I was like, we veered off into here a long time ago. As soon as we brought out the abyss.
How do we get from beards back into direct patient care?
I don't think we need to. I think I kind of said everything I needed to say about it. Does anyone else have any final thoughts on it?
It may be the way of the future. It may be the way of the future.
Or something like it.
Yeah, I wouldn't be that mad. I'll do house calls. Let me see.
Depends on the neighborhood. I know some home health people, they bring a newspaper because they need to put it down before they sit down.
Yeah.
You know, I mean, there are some conditions that are not safe or not. They kind of turn your stomach a little bit. So,
and underneath the newspaper, they have draped over their arm, they have a firearm because they don't feel safe.
Could be too.
Yeah.
I remember doing home health. I go from mansions in Newport where they had 8 bedrooms, 3 people living in this huge mansion. And then an hour later, I'm in Santa Ana in a 2-bedroom, 1-bathroom, 1,000 square foot apartment with 4 generations living in there. And
Yeah.
it's crazy the situations you can get into.
Yeah, for sure.
I bet. Well, on that happy note.
Sorry.
No, I'm just kidding.
No, but I've always thought that's the interesting thing about this kind of work is you do see everything, and you do, I can be in the ER taking care of a little baby with a fever, and then I have a elderly guy who's on his last breath with COPD over there, and I got some idiot 20-year-old that fell off his skateboard, and it's, I've got the millionaires and I've got the street people, especially the hospital in LA, and that's something to me I wanted to experience in my career.
Yeah. And that's the cool part about it.
Not for everybody, but
you don't have to apologize ever, Rogue. We like your I'm here for all the dark and twisty. Like, can we figure out a way to end this badly? I was going to start a new segment where we ended on something positive. And I forgot to ask my sister for a positive something that we had. Or actually, you know what we can do? We can instead read from my book that I got. This is from 1939. It's the Nurse's Dictionary. And some of them are very, very funny, but we can read an ad because the ads are very interesting. How we'll go through the whole thing. I have a whole video that we can do on this. Where's a funny one? On choosing a laxative. Very appropriate for today.
Oh, shit.
So we have on choosing a laxative. You will always be on the safe side in giving your patient California syrup of fig. This delicious preparation supplies the ideal stimulus to evacuate, which is normally afforded by ample fruit in the diet. Absolutely free from synthetic purgatives and chemicals, California syrup of figs brand laxative can be given with the complete confidence to the feeblest adult or the youngest babe. And I am now going to call people feeble. You are but a feeble adult or a youngest babe. California syrup of figs. Get it for your patient.
What if they still make that?
We can find out.
You can get anything on Amazon.
Or did all their profits go down the toilet?
We also
not a dad. Still has that.
You have an excellent dad joke. We also only refer to people as medical man. You can go to your medical man, which means doctor.
Yeah.
So.
Oh my gosh, it is available on Amazon, except now it's by Lieber & Co.
You can get anything on Amazon.
Amazing. I love that. So we're gonna go through these. It has some very funny, a very interesting. Where was the one? Since we're talking about poop already, it was talking.
Favorite topics.
It was talking about different ways to fix. I think I'll find them. Like the treatments for some things were just astonishing. It was like, well, if you are having issues with this, you can massage your stomach, or you can do a 1 liter rectal enema with coffee. Or like the things that it was like you were like, what are we doing? I'm confused. Why? Please, why? Anyway, that's going to be our future entertainment. Next time we'll have an actual happy story. And they called, what do they call? This just has very funny words. Yeah. Everything else I was going to say should stay for Tuesday. I was looking up all sorts of different female anatomy terms, and they were very funny. The seat of your pleasure. I was like, oh, okay, interesting. That's a new term. Okay, well that got off topic really well. And now there's children present, so we will be kind. We will go. Thanks for tuning in today. Let us know what you think about direct primary care. I'm going to mute Chad for a minute. Let us know what you think about direct primary care, or figs, or wearing a wetsuit to your delivery. You have a lot of options there. A lot of things you can comment on. I hope you know that you are not alone, whatever path you're going down today. You, my friend, are more than enough, and you can do hard things. Bye, friends. Oh, also, thanks, channel members. Yay, these are them. If you want to be a channel member, you can sign up down below and join these lovely humans and support the channel and follow these people who are most kindly in our chat today because they're the bomb and they're great. Oh, I forgot to tell Rogue that she can stay on. Well, you can. Oh yeah, you can stay on. You can stay on afterwards and come to the after party. Yes, like if you like dad jokes. And we'll see you later. Bye, friends.